Good morning. I would like to thank you for attending this session. And I would like to introduce my co-chair, Dr. Paul Elbers from Netherlands for Amsterdam UMC.
Yeah, thank you, Despoina, and I wish to do the same for you. So Despoina Koulenti works at King's College in the United Kingdom, but also has an affiliation in Queensland University in Australia. And I'm really amazed to see so many people in this session about endothelial protection. But it's not really surprising because the endothelium is the motor of sepsis, I would say. But we're going to find out. And I'm also very glad that we're talking about protection and not so much about damage or dysregulation. However, we first, of course, need to find out how to assess endothelial damage. And for that topic, I would like to invite to stage Professor Jan Bakker, who also has a double affiliation, as many of you may know. So he's both affiliated with the Columbia UMC in New York, but still has some roots in the Netherlands with his affiliation in Rotterdam. So, Professor Bakker, please enlighten us.
Oh, enlighten you. Oh, that's something completely different. Okay, thank you very much for the introduction. Yeah, the session is about endothelial protection, and I was asked to tell you something about endothelial damage. Not really my specialty, and I think Nicole will give you much more insight into that. I mean, the angle I take. I have no real disclosures. The study we did in COVID and in sepsis was supported by Daxor Company in New York. Now, the endothelial response to sepsis is huge. There's a lot going on. When you look at the endothelium in sepsis patients or in models of sepsis, and there's a myriad of biomarkers and elements that tells you how much damage there is and what the effect is. The question is, so what? If your syndicant is increased in your patient, so what? There are some studies that allude to the effect that if you have these increased biomarkers, that there is more organ damage, like in this study where they looked at survivors and non-survivors and patients with acute kidney injury and without acute kidney injury. And yes, these endothelial markers are associated with more organ failure and even to mortality in patients. But at the end of the day, when you're at the bedside, you don't have access to syndicant. During rounds, you never ask, like, oh, what's the syndicant level this morning? And next to this, of course, this is US practice, so everyone has the stethoscope because you are very important. And of course, the more senior ones have a stethoscope but don't use it. I don't know why my pointer doesn't work, but as you can see, the senior one has a stethoscope in the pocket and doesn't use it. The real experts, of course, just enjoy life and have drinks. So at the end of the day, the question is, if you have a marker of endothelial damage, what does it, let's say, change at the bedside? And I think this is one of the, let's say, more important elements of endothelial damage that you can actually see even in your patients, and that's leakage. And so because of the endothelial damage, water pours out of your microcirculation, and you get edema, and not only edema in your skin, which is usually, at least in my US practice, they always talk about hypervolemia when you have edema. That's not really hypervolemia, but it's leaking outside of your vessels, not only in your skin, but also in your organs. And this is associated, and this is probably the reason you have this organ failure when you, one of the reasons you have organ failure if you have endothelial damage. Now, do we have something at the bedside that will tell you that there is, let's say, leakage on which you can act. You can give treatment like furosemide, or you can stop the fluid resuscitation, stuff like that. Well, actually, I think there's only one really clinically available device that can help you a little bit, and that's the PICO device, where you get the pulmonary blood volume and the extravascular lung water and the vascular permeability index. It's all calculation. There's no assessment of endothelial function in a system like this, but at least it gives you an impression that there is water outside of the vessels, and that's something you probably don't want. And there is this one study from Xavier Monet from Paris, and there you can see, let's say, the interesting aspect of a system like this, because he showed that if you have ARDS, let's say, disease, or let's say constellation of stuff that is usually associated with endothelial damage and edema not related to hydrostatic pressure, that the permeability index is way higher in these patients when you compare it to hydrostatic pulmonary edema. And in contrast, the global end diastolic volume, so the measure of preload, of course, in the hydrostatic pulmonary edema is way higher, where the permeability index is lower. And so this is a measure of the result of endothelial damage that could be applicable at the bedside. There are many ways to measure volume that is not inside your circulation. You have the impedance measures you recently published on the lab values, the hematocrit and hemoglobin level, interesting publications recently. Then you have the CRP and albumin, and the clinical assessment. Clinical assessment is something that you would expect, well, I'm at the bedside and I can assess the patient while doing stuff. That's not really the case. The problem with all of these is that it's time-consuming. It takes time to do it. And the other element is that if you use the hematocrit, you cannot do a fluid resuscitation and measure a hematocrit. It's way too fast, and so it takes time. The study from Chandra was, I think, 36 or 48 hours, the change in hematocrit. So it's timely, and really at the bedside, it doesn't really help. The clinical assessment, this is the albumin, the hematocrit, and you can see, yeah, that you let's say, get more fluid over time, and this is not a good thing. So time is really the main problem in a study like this. Development of this, what they say, clinical assessment, is related to outcome parameters, but as you can see in the table, there's nothing much clinical. It's, again, a lot of biomarkers, but not really something that you can assess at the bedside while you're rounding. One of the elements that is related to endothelial damage is if you start leaking albumin outside of your vessels. And so if you radio-label albumin and you inject it into a patient and you measure the disappearance rate of this radio-labeled albumin, it gives you an estimate on how much endothelial damage or how much leakage you have. This is a time-consuming resource. You have to get the radio-labeled albumin, you have to inject, you have to do blood samples, but in half an hour, you can have an estimate of the leakage of albumin. And that's how I got interested, mainly during COVID, because we had these huge amounts of extravascular water edema in the very early phase of COVID, where there was no treatment. All these patients were like Michelin guys, bloated with volume. And so I got into contact with the Dexar company, and they have this method with radio-labeled albumin. So it's very simple. You inject a known amount of radio-labeled albumin. You take blood samples. You measure the amount of radio-labeled albumin in the blood samples, and the disappearance rate is related to the leakage. There's only basically one study. There's a big study done in surgical ICU in Hawaii, and they published a small abstract where they looked at sepsis, and they found that this elevated albumin transudation rate, so the disappearance of this radio-labeled albumin, was related to mortality, but that's it. Most of this technique is used in renal replacement therapy in heart failure. And it was developed specifically for renal replacement therapy because it makes sense. If you have a total blood volume in renal replacement therapy, you could estimate how much to remove. That's why it was developed. And so the disappearance rate is more or less a sidekick. And so during this initial phase in New York, in COVID, we measured randomly in patients, and we measured on day 2, 7, 11, 13, 14, and 20 in individual patients. And we looked at this disappearance rate and the relation to total blood volume. So the diagnosis, if a patient has edema, in my hospital, they always talk about hypervolemia, and I always said, yeah, well, I mean, hypervolemia in the tissues, but that doesn't mean you're hypovolemic in your system, so in your vessels. So that's what I was interested in. Does this edema and this leakage of albumin results in hypovolemia with edema? And it does. And so the longer you were in the ICU, untreated, there was no active treatment for COVID, and of course it was a mess in the beginning of COVID. The mortality was huge. And so what we found is if we sampled an individual patient, the individual patient on day 2 had less edema and less transudation of this albumin when compared to the patient that we measured at day 20. And basically, the presence of edema had nothing to do with the intravascular volume. So the majority of patients that the clinician thought was hypervolemic was actually hypovolemic because of the leakage, the huge leakage. I'm sorry, my pointer doesn't work. But as you can see, the albumin transudation rate on the left upper graph, it increases over time, and it reaches more than 60%. These were the company keeps a record of every measurement done. These were the highest measurements ever in the whole history of this company. So the leakage was huge. And so then we said, okay, in the later phase of COVID, when we had treatment, we had vaccination, and stuff like that, we said, okay, so now we have a more, let's say, controlled model of COVID. COVID now is basically absent, but in the second phase, it was still sort of a problem. Let's compare it to sepsis, because sepsis, we think sepsis is the, let's say, clinical entity where you have endothelial damage and leakage. And so let's compare the current COVID, which is more or less a controlled disease, to sepsis. And we did 18 patients with COVID and 18 patients with sepsis. And now we did scheduled measurements. So a measurement on day 1, 2, and 3, and 10, 7, and 10. And in some we tried 14, but the majority was already discharged. So we had scheduled measurements in contrast to the previous. The COVID patients were significantly older. They were more sick, at least in SOFA. They also, in Apache, and also more sick when looking at SOFA scores. Look at the, let's say, relatively low sepsis SOFA score in these 18 patients. And the mortality was still not yet really significant, 0.05, but the mortality was still very high at this phase. And we basically found the same. But not COVID. It was now sepsis that was way more leaking albumin than the COVID. And remember, the SOFA score of the sepsis patient was on average 3 that's hardly a sick patient. It's also related to the practice in the US. Many sepsis patients come to the ICU even though they don't need norepinephrine and stuff like that, or not on a ventilator, different than many European countries. But still, if you look at the albumin transudation rate or the total blood volume, there's an abnormality that we saw in the first study, but now the abnormality is focused in sepsis and no longer in COVID. And so the leakage in sepsis is way more than in controlled COVID. And as you can see, this is the albumin transudation rate at every day that we measured, 1, 2, 3, and 7, where we had all patients. You can see that the albumin transudation rate is always higher in the sepsis patient when compared to COVID. And so the let's say, bedside method takes about half an hour, so it's not really fast. Nothing like the PICO, where you get instant results, but at least it's half an hour. Will give you, let's say, significant information about the state of your endothelium and the leakage of very large molecules like albumin. So, in conclusion, endothelial and glycocalyx damage in critically ill is measurable. You can measure it using biomarkers, and these biomarkers or the results are related to outcome. The use of biomarkers is basically absent at the bedside because it's too time consuming. And treatment of endothelial damage is currently not really available. You treat the disease and prevent the response of, let's say, the infection to damage the endothelium. Mainly, that's the main effect. The consequences of endothelial damage for clinical practice is, I think, mainly related to the leakage of fluid. So the leakage because you get organ edema, and maybe even the hypovolemia that we do not see clinically is related to the damage. Several invasive, non-invasive methods are available. The PICO is one that we have available immediately. Hematocrit takes basically too much time to be to have immediate clinical consequences. And the radio-labeled albumin is a little bit time-consuming, but at least you get a result within about 30 minutes. The problem is not available in Europe. The clinical relevance of increased albumin leakage is associated with decreased total blood volume. And so remember, a decreased total blood volume is not really hypovolemia. If you go to the blood donation, you donate half a liter of blood, you're hypovolemic, but you could still do exercise and bike home because you maintain stress volume. So it's a little bit complicated, but a decreased total blood volume in a patient with circulatory failure is probably not a good thing. In sepsis, this seems to be a clinically relevant problem, but we don't have any studies on the value. Thank you very much.
Thank you so much, Professor Bakker. I think we have time for one question from the audience. Yes, I see it there in the corner. There's going to be a mic near you soon.
Super interesting method, Jan, the radio-labeled albumin leakage. Did you validate it against any other device? Is there a gold standard?
Oh, that's a good question. Let's say, piggybacked on the validation they did in all these renal failure patients. So they validated the method, I think about 20 years ago, if I'm correct. The father of the current owner of the company did this, and he was a nephrologist. And so they validated at that time, so I didn't redo the validation. And basically, at the end of the day, I was more interested in the leakage of the albumin than in total blood volume. Given the, let's say, Guyton reasoning I just gave. A loss in total blood volume doesn't mean you're hypovolemic. Circulatory-wise, you can still maintain your same cardiac output with lower total blood volume.
Professor Bakker, if I may, can you maybe speculate a bit on the meaning of the large differences between your findings in between patients and what implications that might have, of course, beyond maybe a different resuscitation strategy?
That's an excellent question, and that's, let's say, the basis for don't treat your patient with algorithms. That probably, if you look at these numbers, if you drive a patient to a given volume or value, that's probably harmful in many patients because the variation is huge. And that's why this is something I think is for personalized care. The company works at some bedside thing, not really available, but still only in the US. But yeah, this is definitely something you have to use in individualized care. And if you want to make a decision, you have to do a measurement.
Do we have time for one more question? A brief question.
Is there still a place for the measurement of oncotic pressure?
How would you measure oncotic pressure?
With a special device, it's available. You can buy it on the market.
Oh, that's what you mean. Oh, okay. I thought you were calculating...
Colloid osmotic pressure or oncotic pressure. Okay.
Well, that's a very good question, because if you have a driving force to, let's say, leak your albumin, basically the only way to get the albumin back in is colloid osmotic, or the fluid to get back in is colloid osmotic pressure. So if you accumulate albumin in your tissues, and that attracts water, the only way to get it back is to maintain your colloid osmotic pressure. It's a good point. There are no studies, but I mean, theoretically, it makes perfect sense. And when I look at the albumin levels of these COVID and sepsis patients, it's all very abnormal low. And so it makes sense. Would be interesting to do a study.
Thank you. Thank you. I would like to welcome the next speaker, Professor Craig Coopersmith from USA, from the Emory University from Atlanta, that will present gut permeability in sepsis. Welcome.
Thank you. So, thanks to the organizers for having me. What's the difference between 2 and 3 letters? Anybody know? When you give a talk on the epithelium, and it's in a session on the endothelium. So I send in a talk on the epithelium, they put me in the session so everybody can walk out for 15 minutes, because every other talk in the session is on the endothelium, but this is a talk on the epithelium. Sorry. So my disclosures are listed here. None of them have anything to do with the talk. They have to do with surviving sepsis and everything else. So I'm going to be talking about the gut, but again, the epithelial barrier. So there is a single cell epithelium that separates the 40 trillion microbes that live within inside of us from us. One cell layer. And that has to prevent unregulated paracellular flux of pathogenic luminal material, while also allowing selective paracellular required for absorption and for homeostasis. And this balance is totally dysregulated in critical illness. Paracellular permeability that's in between cells is controlled by the apical tight junctions, which are functionally and structurally related to the actin-myosin ring. And inflammatory mediators can mediate this significantly. So the first thing we might ask is, can we measure permeability at the bedside? Different from what Jan just talked about. Again, I'm talking about the epithelial barrier. I'm not going to keep reiterating that, but I am talking about the epithelial barrier. So there's only really one study that I could find on this, and this was published a couple of years ago, looking at 21 different patients, giving a bunch of different sugars of different size, to say, can we actually measure a multi-sugar? Can we actually measure permeability at the bedside? And the answer is, in a small number of patients, in 21 patients who were actually getting enteral feeding, that one could look globally at the amount of total gut permeability, and one could also look at the amount of small bowel permeability, but one couldn't actually look at other types of permeability. Not particularly relevant at the bedside right now, but theoretically beneficial. Going backwards to a sec to what a lot of us learned in school, which turns out to necessarily not be correct. So the original concept that I learned about gut permeability in MODS is that critical illness induces hyperpermeability. That's true. And that intact gut bacteria leave the gut lumen into a previously sterile environment. So that makes sense, because permeability is increased. But if it's true, why doesn't every one of our patients have E. coli bacteremia? Because they should. Because you have a trillion E. coli living inside your gut lumen. And yet our patients, if it becomes leaky, should have E. coli bacteremia, but they don't. And in fact, somebody actually did, the Moore brothers actually did this study over 30 years ago in trauma patients, where they actually put portal venous catheters in trauma patients, and they looked to see, are bacterial findable? And they found that only 2% of the time could they find bacteria, and almost always it was coag-negative staph, which was just a contaminant. So the concept that intact bacteria are leaking out is, in general, wrong. It does happen in neutropenic patients, bone marrow transplants and the such, but in general, it's not correct. So how can we understand the concept of gut permeability being increased, yet very few of our patients actually having bacterial translocation? And the reason is that gut permeability is way more complicated than people think, and what's leaking out is what's more complicated than people think too. So in fact, when we look at gut permeability, it's mediated by 3 different pathways. 2 of them are tight junction dependent, 1 of them is tight junction independent. The first one that's tight junction dependent is the pore pathway. The pore pathway, only small molecules can get through. And by small, I mean really small, less than 8 angstroms of diameter. And so anytime somebody hears the word claudin, and there's a zillion, and by a zillion I mean 27, there's 27 different claudins that we have in our body. And they actually mediate things that are less than 8 angstroms. Very, very tiny molecules. The next pathway is the leak pathway. The leak pathway has larger molecules that are less than 100 angstroms, but still pretty small. So LPS can get through that, not bacteria. A portion of the cell wall of gram-negative bacteria, LPS, can get through the leak pathway. And pretty much any other tight junction you've ever heard of, other than the claudins, is mediated the leak pathway. Occludin, ZO, JAM-A. And actually, this is the part that's also associated with mediators of the actin-myosin ring, like MLCK. Finally, the last pathway we have is the unrestricted pathway. And this was actually entirely tight junction independent. There's no size limit, it's tight junction independent, and it occurs at places of epithelial damage, such as apoptosis. And in fact, this is the only route through which bacterial can translocate, other than actually direct cellular invasion. So when people think about the concept of permeability is increased, anytime you hear that permeability is increased and you hear the word tight junction, bacteria can't get through it, but a lot of bacterial products can get through it. So in other words, putting it in a different way, the gut barrier prevents or allows molecules of different sizes from leaving the gut lumen. And these range from tiny, tiny, tiny molecules to macromolecules like endotoxin to attack bacteria, all going through different pathways. Each is controlled by a different pathway, and even if bacteria don't translocate, bacterial products that are smaller can translocate. I hope that people know, I'm not going to go over this slide in detail, to know that the gut actually has distant effects. Any organ that you can think of, there's a gut blank axis, a gut lung axis, a gut heart axis, a gut brain axis, a gut, you name it, there's a gut something axis. And importantly, all the pathways that I spoke about are dysregulated after sepsis. All of them. The pore and the leak and the unrestricted. So I have 8 minutes and 40 seconds, and for the next 7 minutes or so, I'm going to talk about mice. And then I'm going to come back. So it's not bad enough that I'm not talking about the endothelium. I'm not even talking about patients. So I'm going to talk about mice for the next 7 minutes or so, but then I actually promise I will come back to patients at the end. So I'm going to send some talks that we're doing in the lab, looking at the 3 different pathways. So this is the leak pathway. And when people think about leak, at least in the gut, they frequently talk about FD4. So when people talk about gut permeability, they say we give FD4, we gavage it, and then we measure does it appear in the bloodstream or not? Simply put, if you gavage something like through an NG tube and you're not leaky, it'll come out in your stool. If you're leaky, it'll leak, it'll end up in your bloodstream, and so you can measure its appearance in the bloodstream. So people think that the permeability is only FD4, which is the leak pathway. It's only 1 of 3. And this is actually data we did a number of years ago, actually looking at FD4 appearance in the blood after pneumonia. So we're not touching the gut. You give an animal pneumonia, and in fact, you see that the leak pathway is totally up. This is the pore pathway. It's kind of a crappy slide because it's intended to show something else, but I'll just show you that the pore pathway is equally up to 48 hours. And the unrestricted pathway, which is this marker really of apoptosis and cellular damage, is also increased. So we've asked the question, what happens if we target them? So we target the POR pathway, and I lied ever so slightly because my next 1-2 slides are going to be about humans. So we published this 2 weeks ago in PNAS. So we started with human tissue. I don't know if any of the reviewers are in the room. If the reviewers are in the room, you made us half the number of septic patients we had because we had SOFA scores on 2 people, on about half the patients. And we actually had about 50 human septic guts and about 56 controlled patients who underwent resections for cancer. But because we didn't have SOFA scores on people, they said even though you have perforation, you can't prove that they're septic. So what we ended up publishing is on 27 septic patients that we did have SOFA scores on, their intestines after abdominal perforation versus people who had resections for cancer. And we looked at Claudin-2 levels. Again, Claudin-2 is part of the POR pathway. And what we found is that in septic patients, because the next bunch of things are going to be in mice, in septic patients, there's a marked upregulation of Claudin-2 in the gut epithelium of septic patients compared to have patients who have intestinal resections for other reasons. When you reverse translate it and you say, does the same thing happen in mice? Because we know that mice are not people. In fact, the exact same thing happens. We see the exact same upregulation, which now says, okay, what happens if we knock that out? So I showed you this picture before, but I showed you only look at the bottom. This is what happens when we knock out Claudin-2. So if we knock out Claudin-2, on the top we have wild-type animals, POR permeability goes way up. When we knock it out, POR permeability normalizes. So what happens? Bacteria can't get through this. LPS can't get through this. But smaller molecules can. Does it have a distant effect? In fact, it has a marked distant effect. In fact, it totally changes your cytokine response. You see here a difference in IL-1 beta, in IL-6, in IL-10, not IL-10. Marked changes. Small molecules are going through, not bacteria, and that changes your host immune response. And then by changing the small molecules in inflammation, in actuality, you totally change survival. So by changing the smallest micromolecule permeability, again, sorry moderators, epithelial permeability, you can actually significantly change mortality. What happens if we look at larger molecules right now? So now we're looking at the leak pathway, what people think of, which is FD4. And so the first thing we looked at is MLCK. For those who don't know what MLCK is, myosin light chain phosphorylates is moderated by MLCK, myosin light chain kinase, which ultimately changes the barrier through tight junctions to the actin-myosin ring. So I already showed you this slide. This is what happens to leak permeability after sepsis. It goes markedly up. What happens if you knock out MLCK? Permeability doesn't change at all. And if you change permeability to smaller molecules than bacteria, but bigger than we see through the POR pathway, what happens to systemic inflammation? This is interleukin 10. So we don't touch interleukin 10, but what you see is you're markedly changing the host inflammatory response. And when you markedly change the host inflammatory response, simply by changing permeability, what happens? You see a marked increase in survival. The last one I'm going to show you about experimentally is looking at another portion of the leak pathway, but directly one of the tight junctions. And by the way, I'm going to tell you up front that this is meant to confuse you, not to simplify it. So I've showed you Claudin-2 on the left already. That was the first thing. Next to it, we see a marked upregulation of JAM-A, junctional adhesion molecule A. So what happens if we knock out JAM-A? Well, we see exactly what we think would happen. We see an increase in permeability. So far, so good. When you think an increase in permeability, again, leak pathway, bacteria can't get through, you might think I'm going to change systemic inflammation, and that's going to change survival. So we have a worsening of the leak pathway. What do we expect to happen to bacteremia? Not this. You would not expect bacteremia to go down. You'd expect it to be either unchanged because bacteria can't get through there, or you'd expect it to go up because you have a worsening leak, but in fact bacteremia goes down. What would you expect by systemic inflammation? You'd expect it to get worse, not to get better, but in fact it gets better. And then what would you expect to survival? You would expect survival to get worse, not better, but it gets better. So the reason I show this is to make it clear that it's not actually one specific molecule, because unlike what Dr. Bakker was just talking about, when you can look just at specifically endothelial leak, a lot of these things that control tight junctions are present on multiple cells. And in this case, the effects of JAM-A on the neutrophils and the lymphocytes are totally transcending its effects on gut epithelial leak. So even the leak gets worse, it's transcended by other things, which is relevant for if we try to target this at the bedside. Finally, I'll ask, is permeability dependent upon apoptosis, which again is epithelial damage, and this is where bacteria can come through. So this is showing you that apoptosis does in fact go up in mice, in pneumonia, and if we bring it back to patients, apoptosis goes up in patients as well. So if you take our patients who are septic, they have a marked increase in gut epithelial apoptosis. And so what happens if we prevent that apoptosis? Do we change permeability? You would think the answer would be yes, because you have a big leak of bacteria now going through holes made by dead cells. What happens if you prevent those cells from dying? In fact, you can actually normalize permeability. So it's not just that you're normalizing apoptosis, you're also normalizing permeability, which is actually also associated with improved survival. So I told you at the end that I would in fact ask the question, does this matter in patients? So thank you for listening to me talk about the epithelium and also about mice, which I know none of you signed up for. But does this matter in patients? Well, again, through the leak pathway, what gets through? LPS. So I know that we think about LPS as endotoxin, but look at this study over here. Low-grade endotoxemia is associated with cardiovascular events in community-acquired pneumonia. So this isn't somebody in a septic shock. This is simply an increase of LPS. Where does the LPS come from? It comes from the gut lumen. The LPS comes from the gut lumen through the leak pathway, and ultimately it's associated with adverse cardiovascular effects. And if you look at the amount of LPS that one comes through, actually by quartile, the more LPS you have, the higher mortality you have. This is the final study I'm going to show, and this is a fascinating study that came out last year. Dysbiosis of microbiota immune metasystem in critical illnesses associated with nosocomial infection. That rolls off the tongue, right? Okay, so on the left, we are looking at the microbiome of patients. And what we see is if Enterobacter is increased in patients, you see a worsening mortality. Getting back to what I said before, you might think it's just the Enterobacter coming through. But it's not, for the same reason that we don't see E. coli bacteremia in our patients. If you look on the right, you see that the amount of nosocomial infections with Enterobacter has a relative risk of 1. But the amount of nosocomial infections of any type has a relative risk of 7, because it's not intact bacteria that are translocating through. It is bacterial products from an altered microbiome that go through the pore and the leak pathway that secondarily interact with our immune system and give us a worse outcome. So in conclusion, gut permeability is increased in sepsis. It's more complicated than people previously understood, and all three pathways are mediated through entirely different planes, some that are tight junction dependent, some that are independent. Studies in mice and preclinical studies show a direct role of targeting the pathways for improving survival, and associative studies in patients suggest that targeting gut permeability is actually a potential therapeutic target in sepsis. Thank you very much for listening to a talk you had no idea I was giving.
Professor Coopersmith, thank you for your excellent talk on epithelium. And unfortunately, no time for questions now, but at the end, if we have time, the audience can ask questions.
Yeah, so hopefully we can take the room back to the endothelium, inviting Professor Pickers from Nijmegen in the Netherlands. We heard from Professor Bakker there's no therapy to address endothelial damage. So I hope you're going to tell us differently.
Yes, I will tell you about the struggle indeed, and some signs of light at the horizon likely. So back from mice to patients and from the epithelium to the endothelium again. So what is clear about the endothelium is quite a lot actually. In the first place, this is quite a large organ. The weight of all your endothelial cells together is about 1 kilogram, and the area surface of your endothelial cell layer is about 5,000 to 6,000 square meters. So it's a huge organ actually. And we know it plays a key role in vascular homeostasis, and with that I mean the vascular tone and permeability that was discussed by Jan Bakker already, but also hemostasis and inflammation. And we do know that the function is disrupted in sepsis patients, and therefore it might have therapeutic implication, of course. However, there are also challenges. One thing is that you need some degree of endothelial dysfunction to clear your infection and to repair tissue damage. But however, if this is too excessive, then this dysfunction can be harmful. So it's getting right the balance that is the challenge, because you need actually some permeability increase for your immune cells to get out of the vasculature, the circulation, get into the tissues and fight the bacteria that are causing their infection. However, if this is too systemic or too severe, of course, then septic shock may occur, intravascular hypovolemia, etc. So these different processes that are mediated by the endothelium, as depicted here, are, of course, there are underlying mechanisms of actions and processes that are important, and they interact with each other. That is making it even more difficult. So to keep some focus, I will focus on 3. Nitric oxide, on vascular tone, and focusing on permeability mainly, adrenomedulin and vasopressin, because these pathways are tested as therapeutic entities so far. So first, nitric oxide. This is a pretty old molecule. It's been around for over 500 million years. But at the same time, there's a very short half-life of only seconds. And that's the reason why it's very difficult to measure, because before you have the blood in the tube, it's gone. And it took till the 1980s before it was discovered, indeed, that nitric oxide is responsible for the endothelium-dependent vasodilatory effects. Then 7 years later, it was identified as nitric oxide. This became the molecule of the year, and later on the people received the Nobel Prize for their work. And in the meantime, things got more difficult, of course. To keep it simple, there are actually 2 main ways that you can produce nitric oxide. The first one is the constitutive one. So this is produced by your endothelial cells all the time. And it's a calcium-dependent effect, and little amounts of nitric oxide are produced, and this influences your vascular tone. The second one is the inducible nitric oxide. This is induced, for example, by inflammation. And at that moment, virtually all organs can start to produce nitric oxide. It's calcium independent, and the amount of nitric oxide that is produced is thousands of times more than the amount produced by the endothelial form of nitric oxide synthase. So nitric oxide is the main driver of the vasodilatory response and leading to hypotension that we see also in septic shock patients. And in the clinical setting, we can try to inhibit this. And we used in humans the non-specific LNMA mainly. And indeed, a study by Jan Bakker here, if you infuse a non-selective NO synthase inhibitor, you increase the blood pressure, but at the same time, it's mainly the vasopressor effect, so you decrease cardiac output. And this might be like a negative thing, especially in patients with already a low cardiac output state. So based on this, a multi-center trial was done in 800 patients, but unfortunately, as you can see, survival was significantly worse than placebo treatment. And so it was an absolute difference of 10%, so that means that the number needed to harm 1 patient more death was per 10 patients treated. So in the small print of the article, it's actually shown that indeed overall there is harm. But if you look in the subgroup of patients that were treated with a lower dose of the synthase inhibitor, there was a significantly improvement in survival. And this, I want to stress again that this was a non-selective inhibitor, so it's inhibiting both amniocentesis, and if you use a lower dose, there might be a benefit. So this ended the story of nitric oxide inhibition, but actually, if we would use a more selective inducible nitric oxide synthase inhibitor, there might be a benefit, or if you use less of a concentration, there might be a benefit. The second protein I want to discuss is vasopressin. Again, this is even older. Oh, it's around for 700 million years already. And I love the way in the old days how science was done. So in 1895, it was found that there is a vasopressor effect of what later turned out to be vasopressin. How did they do it? They took rats, they took out their pituitary gland, like a couple of dozens of them, put them in a mixer, the one that you have in the kitchen, and then infused that in another animal, and then blood pressure increased. So there must be a vasopressor in that gland, and this is how vasopressin got its name. And it took many, many years before it was indeed thought that this might have a role during vasodilatory shock. Now, vasopressin, we know how it is produced and stored and then released, and then there are several organs where it acts on, and it is dependent on the concentration, but also on the kind of receptor. So there's water retention that we know very well in the kidneys. Higher concentrations have vascular effects, but actually 2 types of vascular effects. There's a vasodilatory effect as well, mediated by the oxytocin receptors, but there's also the V1 receptor-dependent vasoconstriction. So that's the reason why you should not infuse vasopressin very quickly, because then the vasodilatory effect is showing the majority of the effect, and you can have a decrease of blood pressure. And there are also cardiac effects, and it's not really clear if there's a positive or negative inotropic effect. Overall, the idea is positive. Well, this trial is very famous. It's pretty old in the meantime, the FAST trial. So this was a trial that for the first time in a randomized blinded fashion, large enough to show an effect on outcomes. So patients that were on norepinephrine were treated with vasopressin up to 0.03 units per minute, and the main outcome was survival. And they had a prospectively defined secondary analysis in the patients with mild shock. The idea was that the patients with severe shock, with high norepinephrine rates, would benefit more because of the norepinephrine sparing effect, so you would have less side effects of norepinephrine. I'll come back to that later. So overall, the trial was neutral. There was no effect on outcome. Mortality was similar, both 28 and 90-day mortality. In the secondary analysis, where they looked at the patients with mild shock, actually they found that in mild shock there was an improvement in outcome. And this was in contrast with the original idea. As I said, the idea was if you need a lot of norepinephrine, the benefit would be more pronounced because of the sparing effect. Now, actually, we think maybe the ones with a lower norepinephrine infusion rate are the ones that were treated earlier. So maybe it's not the absolute amount of the infusion rate, but the timing of treatment, and that early treatment with multiple vasopressors might be of benefit. So there is an effect there, but this was a secondary analysis. Then the vasoconstrictive effect is mediated by the V1 receptor and also the permeability effects of vasopressin. So there is a selective V1 receptor agonist that is called celepressin, and this one seems to be even better. So here, if you see, this is an animal study. If you compare to vasopressin and norepinephrine, the celepressin is responsible for less capillary leakage in the lungs. So there's a benefit there, and this translates also to a mortality benefit in these animals. So therefore, the company Ferring decided to actually use this selective V1 receptor agonist to treat patients with vasodilatory shock. And they wanted to show indeed that there is a clinical benefit of this effect on permeability. And if this was the case, the idea was that you were better able to maintain your circulatory volume so that you would be weaned off total vasopressors earlier, so you had more shock-free days, and that it would also be of relevance for the duration of mechanical ventilation. So this was the main outcome, to show a benefit on shock-free and ventilation-free days. This was the Sepsis Act study. It was published in JAMA, and what they found, and this was a double-blinded study. Actually, what they did very cleverly was that in the placebo syringe, there was noradrenaline. So patients were on open-label norepinephrine, and then you got the study medication with either with celepressine or norepinephrine. So if you actually start a study medication, also in the placebo group, blood pressure would go up because of the norepinephrine, and then you would lower the open-label norepinephrine, so the total dose should stay similar, but you would not be unblinded because of the acute hemodynamic effects. Well, then if you look at the total amount of norepinephrine needed, you can see here that celepressine was able to increase blood pressure and lower the infusion rate of norepinephrine that was needed to maintain blood pressure. The fluid balance did change a little by the treatment, but this was a very small effect. It was significant, but the difference was only 26 mils per hour, per day, I think even. So a very irrelevant, clinically irrelevant difference. And also the primary endpoint, to look at days free of shock and free of mechanical ventilation, was completely not different, and therefore after 800 patients the trial was stopped prematurely because of futility. So this is the struggle for vasopressin or celepressin so far. The next protein that I want to discuss is adrenomedulin. So adrenomedulin is another protein that is really important for vascular permeability. So adrenomedulin is present in your bloodstream, and it is induced if you have inflammation, all kinds related to septic shock, ischemia, etc. It actually has a positive, a beneficial effect on the endothelium. So it improves the barrier function if it's inside the vasculature. But adrenomedulin can freely diffuse to the interstitium. And on the vascular smooth muscle cells, it actually has a vasodilatory effect. And so it might lower blood pressure. And this is something that you might not want in a patient with septic shock. Now, the intriguing point is that if we have this antibody against this adrenomedulin, it's a non-neutralizing antibody. So that means that the antibody is capturing the hormone, but it's not neutralizing its function. So by capturing the hormone, it's actually draining the adrenomedulin from the interstitium into the circulation. So if you give this antibody, there's an acute increase of adrenomedulin levels that you measure in the circulation. And this has the beneficial effect on the endothelium because it's still working. It's a non-neutralizing antibody. So this is a good thing for edema formation. And at the same time, because you drain the adrenomedulin from the interstitium, you have less vasodilatory action in the vascular smooth muscle cells. So this is the idea that the mechanism of action is beneficial in vasodilatory shock situations. Well, there's a lot of animal data confirming these benefits. So a double-blinded, placebo-controlled RCT was done in 300 patients. And in this trial, another thing to highlight is this was one of the first biomarker-driven trials, so a more personalized approach. And so patients with septic shock were selected, but then bioADM was measured, and it had to be above 70 picograms per milliliter to make sure that this system was activated in this specific patient. Treatment was really quickly had to be started within 12 hours, and so we had 300 patients in the trial. And what we found was that in the patients that were treated with placebo, from day 0 to the first day, they actually had a further worsening of their SOFA score of approximately 1 point. While this was not the case in the patients treated with the antibody, and then over time there was a parallel improvement in both groups. So this first difference was significant. The primary endpoint, of course, of this phase 2 trial was safety, and no safety issues emerged, but we looked at some signals of benefit as well, and this was one of them. It's not surprising that in a 300-patient trial there's no significant effect on mortality. As you can see here, there might be a trend, but it's far, far from being significant, and this is also not what we expected with this number of patients. So what was a predefined secondary analysis, I'm going to explain to you now. Because there is another biomarker that is also related to bad outcome, and it is DPP3. So you have patients with low bioADM and low DPP3, and these are the ones that will survive anyway. You don't want them in your study because they will dilute the signal. There are patients with high bioADM and high DPP3, and they will die anyway because both biomarkers are independently predicting mortality. So we wanted to look at patients with a high bioADM, because that is the process that we try to modulate, but with a low DPP3, with the idea that they are not dying because of this DPP3 pathway, and so the therapeutic efficacy might be more pronounced in these patients because it's mainly the bioADM that is driving their bad prognosis. And if we do this, so we had the total group and we had the subgroup of patients with a DPP3 level below 50, the beneficial effect on SOFA became more pronounced. And again, this is the total group, and then the subgroup of patients with a low DPP3 level, also the mortality benefit, the survival benefit, I should say, is more pronounced in a subgroup of patients with low DPP3 levels. It's still not statistically significant with a p-value of 0.08, but there is a strong trend. I want to end with this. This is not necessarily endothelium treatment, but this is a meta-analysis showing all studies investigating non-catecholamine vasopressors against norepinephrine. And as you can see, it's really difficult to show a benefit of new treatments compared to the current standard of care. And if you look at the trial sequential analysis, you can see the blue line that will eventually have to go up to show a benefit or down to show harm, and it's still not there if you have all the trials combined of these different vasopressors. So it's really difficult to show a benefit, and if you can calculate the required amount of patients that you would need to find a significant benefit, and it's about 5,000 patients. So this is indicating that there might be benefits in using alternative compounds, but you need to be sufficiently powered to show this benefit, and that makes it difficult. So my conclusion is, and this is my Donald Trump impersonation, the endothelium is a huge organ. It interacts with inflammation, coagulation, permeability, vascular tone, etc. It's clearly dysfunctional in sepsis, and that means there is potential for therapeutic benefit, but there are issues and challenges. We need to assess function. How can we do that to know if it's there or not? Can we select patients that are more likely to benefit from these treatments and use enrichment? And even there might be within one patient differences between organ to organ. And there's this yin-yang effect that there might be a delicate balance between inhibiting too much or too little. And with that, I thank you very much.
Thank you. We don't have time, unfortunately. I would like to welcome, thank you very much. I would like to welcome our next speaker, Nicole Juffermans from Erasmus Medical Center of Rotterdam, that will discuss about plasma as resuscitation fluid. Welcome, Nicole.
Good morning, dear colleagues. I'd like to draw your attention to the glycocalyx. I figured by now in this session you would have heard about it. It's this hairy carpet lining the inner cell wall of the vessel. And why is it there? Well, it's the first contact with the blood. And if you ever wondered, why isn't my blood coagulating when it comes in contact with the vessel wall? It's because of this hairy carpet. It keeps the blood anticoagulated, right? And these hairs, they can also feel the flow. I know I sound a little bit like Armin van Buuren, but the glycocalyx can actually feel the flow of the blood, and thereby it is sensitive to changes in the volume load of the blood and in the vasomotor motor tone. So in other words, it has mechanotransductive capacities. And it also has a function in permeability as it is protective in keeping the vessel wall barrier integrity. So if there is shock, there is shedding of this glycocalyx. And what happens then? You get exposure of the procoagulant surface. And when the problem is really severe, it will also damage the clefts between the endothelial cells, and there will be permeability if the basement membrane is also disruptive. So then we have this problem of endothelial permeability. And this is studied and shown in sepsis. But although you may think that shock due to major surgery or trauma or sepsis are quite different in their etiology, this loss of glycocalyx is actually found in all forms of shock. So if we speak about endothelial permeability and adverse outcome, because these two are linked, and then we speak about fluid resuscitation, it speaks to the mind that if you have severe endothelial permeability and you start to resuscitate your patient, the more fluids you will give, the more you will increase your pressure gradient, and the more edema you may form. Well, whether that is true, this is what we are going to talk about. So I think the first question that we need to answer about the glycocalyx shedding, is this due to the severity of the shock, or is this due to the volume of the resuscitation fluids that we are giving? Because obviously these two are intrinsically related. We have had this kind of observations about the problem. And you can see 3 lines. They represent patients with sepsis, severe sepsis, and septic shock. So the more intense your shock or the more sick you are, the more glycocalyx shedding that you have, as depicted here by a constituent of the glycocalyx, which is heparan sulfate, which you can then measure in the circulation. What you also see here is that the more fluid that has been given, the higher these levels of circulating heparan sulfate are. So thereby both shock severity as well as resuscitation volume are both associated with loss of glycocalyx. So is there a mechanism? I always think if there is a mechanism that makes things more credible and more tangible. So the mechanism that has been proposed after fluid volume and glycocalyx shedding is that due to the increase in volume and these mechanotransductive capacity of the glycocalyx, you will get an increase in your atrial natriuretic peptide. You will get stress on the endothelial cells, and then they shed this AMP. We use it in clinical practice. And what happens then? Then it induces an enzyme called matrix metalloproteinases, and they are shedding enzymes. They start cutting the glycocalyx, and this then may contribute to endothelial permeability. So that is at this point in time, merely a hypothesis. So are there any clinical data related to the amount of clear fluids and shedding of the glycocalyx? We don't have real trials. We only have post-hoc analysis of these randomized controlled trials comparing restrictive versus liberal volume. And you can see here quite a lot of volume has been given, 40 versus 60 mLs per kilograms. And in this post-hoc analysis, all these constituents of the glycocalyx were measured. And in fact, mixed results were found with indeed a decrease in some of these constituents, but no effect on other components of the glycocalyx. So mixed results there. There has been another large observational study in sepsis patients finding no relation between volume of fluid and glycocalyx shedding, and these authors reason that the glycocalyx shedding is merely due to the severity of the shock. And I'd like to point your attention to the fact that the fluids in this study that were given were clear fluids, but also blood products and colloids. So thereby, I would like to add a layer of complexity to the question at hand. It's not only about whether it's the shock severity or the volume of fluid, because I think the word is still out, whether which one of those is more responsible for glycocalyx shedding and endothelial permeability, or is it the type of fluid that we infuse? In particularly, maybe it be related to the protein content of the fluids that we are giving. And the hypothesis is that if you infuse a protein-rich content, you will have a preservation of your glycocalyx, whereas if you infuse clear fluids, you will increase shedding. Why is this? Well, this is based on an observation already 10 years old in vitro studies. If you take an endothelial cell layer, and here heparin sulfate, one of the constituents, is colored, it's in green. And if you then incubate it with different types of fluids which differ in their protein content, the less protein you have, the more shedding you will have. But then you can also ask the question, yeah, but why does that occur? Well, maybe this, again, is due to these, this hairy carpet that feels the flow of the blood, that is sensitive to differences in the component of the blood being protein-rich or diluted with clear fluids. So these hairs, they go with the flow and they sort of tug at the basement membrane. And the idea is that maybe this can induce permeability. So let's discuss some data comparing plasma to clear fluids. And we will go to models. This is an experimental model of sepsis following cecal ligation and puncture, so abdominal sepsis. And these animals were randomized to receive either plasma or clear fluids. And you can see the clear benefit in survival curves, which are way better when infused with plasma. But if we then look at the volume, what has been given to these animals, there's a huge difference. It was a lactate-based resuscitation study, and the animals receiving plasma received much less volume than those receiving clear fluids. Let's look at another study. It's traumatic shock, but that doesn't differ, right? Because the shedding problem is the same in all types of shock. And you can see, again, shock induces shedding of the glycocalyx, and this was, again, reconstituted after infusion of plasma, but not after Ringer's lactate. But again, here in this study, a huge difference in the volume of the fluids that were given. So are there any patient data? Yeah, this is the results of the PAMPER study, which was a study on pre-hospital plasma. Bleeding traumatic patients were randomized to receive either plasma or standard care, which was red cells and fluids. And there was a survival benefit in those patients randomized to receive plasma. Okay? And they did a sub-study. They took blood and they measured glycocalyx components such as syndicon, and they saw that in the patients receiving plasma was associated with a reduction in the amount of syndicon that was shed. But again, if we then go back to the intervention, we can appreciate that this was again also associated with the receipt of less volume. So I think, again, this question is very, very difficult to tackle and to answer with patient data, given that volume of fluid is so much related to the severity of the shock. But if you want to differentiate, you can do it. You can model it. And this is what we've done. So we took a rat model of pneumonia, inoculated with Streptococcus pneumonia. So then severe pneumonia developed. And then animals were randomized to receive an equal volume of plasma or clear fluids, lactated Ringers. And then they were, after some time, they were sacrificed. So what was the result of this? That plasma, compared to Ringer's lactate, or non-resuscitated animals, reduced the amount of leakage as measured by injection of a label of albumin. So we labeled albumin and then measured the leakage of this albumin in the tissue and we saw that it was reduced with plasma, but not with crystalloids. However, other parameters of organ dysfunction, such as edema or the histology of the organs, that look the same in the arms. So if there is an effect, it's a little bit of a mild effect. But then this still doesn't answer the question, was it the... so we figured maybe we should move to a more severe pneumonia model. So that's what we did. Again, we inoculated a higher dose of pneumonia, and animals were really sick, and they needed rescue therapy with mechanical ventilation. So this was combined with mechanical ventilation, and we had 3 groups. We had one group with 10 mLs per kilogram with clear fluids, 10 mLs of kilograms of plasma, or 30 mLs per kilogram of clear fluids. So what we saw is that in blue are the healthy animals. So in time, if you put a healthy animal on a ventilator, after some hours the blood pressure will decrease because it's not handled very well by these animals. So in blue is the healthy, and in the other figures are the resuscitated animals. And what we saw is that increasing your dose of clear fluid doesn't help in maintaining blood pressure anymore. Whereas at all time points, the animals receiving plasma had higher blood pressures over the time. We had some problems measuring the leakage of the fits in this model, but we did measure some, let's say, markers of endothelial activation, and again, the syndicon, which is shedding of the glycocalyx. And what we saw is that there is a dose-dependent increase in levels of these markers if you increase your dose of clear fluids. The amount of plasma given resulted in a bit of a reduction of the syndicon. And the same holds true for cytokines, in a sense that you can see a dose response in the amount of clear fluids associated with more production of inflammatory cytokines, which is, let's say, inhibited or less so if you give plasma. However, in this model, again, plasma was not associated with inhibition of edema in the organs. So now we move away a little bit from shock and lactate, and we try to model the same question using a human volunteer. Injection of LPS is that you get fever, you get chills, you get decrease in platelets, you get a decrease in monocytes, you get activation of your endothelial with all these kinds of markers. So it's an inflammatory model, and it's in the human compartment. So we randomized the volunteers to receive a fixed dose of either omniplasma, which is the plasma results that are still being analyzed and ongoing, is that those receiving omniplasma had reduced levels of this MMP9 compared to those receiving crystallites. And if you remember well, this MMP is an enzyme that cuts the glycocalyx. So we figured that less of this component may be protective in protecting your glycocalyx. But if we then measured the syndicate, and we are currently looking in other markers that are more downstream from MMP9 to see whether there is any more effects. What does happen if you infuse omniplasma in recipients that really do not need volume, you indeed get a stressed volume in your vessels, and you get an increase in your AMP compared to crystalloids in the same volume. So that also may be an explanation why we also found effects of activation of the endothelial markers, such as ICAM, which was significantly higher in those recipients receiving omniplasma. So this is work ongoing. We'll measure more in the near future. I would like to end with drawing your attention to something else which is related to plasma transfusion, but is plasma exchange, which is of course different because you infuse something and you take stuff out, so it's a different intervention altogether. But using therapeutic plasma exchange in septic shock patients has shown some benefit on interim markers. Again here, these are endothelial cells colored with a constituent, the heparin sulfate, the constituent of the glycocalyx, and it's gone after shock. And if you then, after one session of therapeutic plasma exchange, you can see that this kind of layers, that they are regenerated in some way. So with that, I'd like to conclude. I did not mean to confuse you with all of these data. The message that I wanted to tell to you is that this permeability is both due to shock as well as to volume. I've showed you associations, some sub-studies from trials and experimental data that all point in that direction. Plasma may allow for a reduction in the volume needed to maintain a targeted mean arterial pressure. A specific mechanism may be there, maybe it's related to a decrease in MMP9, but it may only be beneficial in patients with severe shock needing large volumes, and I guess this is subject to further study in the near future. Thank you for your attention.